Hello, dear listeners. This is Hat in the virtual studio, and you are here for another episode of Bundle of Hers. Yay! And with me in the virtual studio today, I have a very special guest, and it's a guest that we all know very well. It's Siale. Woohoo! Say hi, Siale.
Hi, everyone.
Before, what was it, like episode, I don't remember the numbers, but you had heard her a few weeks like prior and you were like, oh, love Siale. Guess we only get a taste of her for one episode only per season. But we lied. She's back. We loved her so much. We asked her to come back. Maybe you'll like be more like, you know how in TV shows there's like the recurring guest stars. Maybe you're like a recurring guest star.
But yeah, I'm happy to be back. Thanks for having me back.
Yeah. And the reason why we're like having Siale back is, if you all remember a few episodes back, we were talking with Siale a bit about health policy and briefly about her time with Tonga. That conversation was like really great and like we covered a lot of ground, but the big hope this time is to like continue having conversation about a different aspect of public and population health. And who better to have that conversation with than the person who studied public and population health. For this episode, the topic that we really want to talk about is actually like focusing on health systems. And the significance about wanting to focus on health systems is because, and I guess before I state this, I should give that disclaimer that the views that are expressed in this episode are our personal views and do not reflect the views of the institutions that we belong to or the institutions that this podcast is associated with. In addition, I wanted to give a second fun disclaimer, and it's that Siale has in her room a cute little child, her son. So you might be hearing kid noises throughout this room because he is 2 and he is ready to show the world who he is. Now that I put that disclaimer, I want to like say that healthcare is a human right, and it is something that is like critical for us to be able to function and to like meet our basic needs. And all to say is that along those lines, I think the concept of like universal healthcare is a very important concept to like consider and something like very much important to think about in terms of health policy. And it comes and is really connected to the whole like topic about health systems. And the reason why this is significant for like our topic of exploration and discovery is, I don't know about you, Siale, and I'd love to hear your thoughts about it. But for me, I felt that when I started in medicine, I was a pretty like hopeful, like passionate person about really making change. And as I've continued throughout medicine, I've begun to like realize a lot of the nuances and about what it means to be able to provide care for my patients. And I've realized that it is very much ingrained in the way that our health systems function. And so it's something that I keep wanting to learn, and it's something that I keep like discovering and reflecting about. And I'd love to hear about your thoughts.
Yeah, I felt like I entered medicine and still feel the same. Healthcare is like an essential right that belongs to everyone. And it's unfortunate that we have so many systems all across the world that don't align with that thought. And so I think some of the reason that I started to dive into like health systems and trying to understand them is because of this fundamental like belief that I think everyone deserves healthcare. And I think understanding the systems and then like what comes with that. And so what I love, like one of the things about being Tongan is that in Tonga, they believe that healthcare is a right and everyone has healthcare and the government pays for it, but that does come with some drawbacks in how they function. I think most people that are probably listening, they all agree with the view that healthcare is a right. And I think being able to understand the system and like what the drawbacks of various systems are. So when you talk health policy with someone, or when you propose an idea to legislatures or people who sit at the table, that you understand like what the drawbacks are, because that's what they're always going to refer to when you bring these ideas to them. What's the downside? What's the cost? Which is usually the downside. I think it's important to like keep having these conversations.
And I think like to take it a step back first too, because for instance, for me, before I even like started thinking about medicine or even before I entered medical school and did population health, my understanding of what when people talked about health systems was very skewed, right? And I think it's like helpful to kind of give that framework for people to understand what we're talking about when we think about health systems. And I'd love to hear like what you've like learned, like how do you like approach it, or like how would you explain it to like most people?
Yeah, I guess it's going to be different depending on what level you're talking about. But I think to step back, what is the US healthcare system and like what is the structure of it? Because I don't think I really even understood that like as a medical student until I had like more time to dive in. So the US healthcare system has two parts to it. It has both a public part and a private part. And what public versus private means, who is paying for it. So public refers to the government pays for it, and that's in the US, that's only given to people who are above the age of 65 or people who fall below a certain like income level. The other part of it, the private system, which like we're all familiar with, that's like private healthcare insurance. That's insurance that you get from your employer, and that's often determined by like how much money you make, like how good of a job you have. It really will determine how good of healthcare coverage you have. And so when you refer to systems, it just sounds like it's money, but the reason it's all related is because it will tell you what type of care patients can and can't receive depending on the type of healthcare they have. And that impacts like, sounds like money, but it's all like interconnected about what resources are available to them, where they can seek care, and the bill that they're left with afterwards, and what ends up happening in the big picture.
And that's like something that I feel like really deeply, because a lot of times, like, for instance, we can think about it as high level care for like certain specialties like cancer. A lot of times, like what we'll hear a lot of people talk about is, oh, we need to like file to your insurance for prior authorization and to like get that approval. So waiting for insurances to give approval to like start care can sometimes pause care. Or if the insurance doesn't approve it, this means that what medications we're able to prescribe to you will very differ. And I feel it's really interesting because for me, like I'm currently at a residency program that's multi-site, and I really appreciate it because it means I rotate at a county hospital, which is affiliated with the San Francisco Department of Public Health. And then I've rotated at our academic hospital that's affiliated with the like institution, the academic institution that I'm a part of. And I've also rotated at a hospital that's like basically it's the Kaiser network, which is like this network of like its own like insurance and like everything like that. It's like this whole like system of special like care like within its own like insurance system. And it's so interesting seeing how we care for patients differs. It can be the exact same diagnosis, but what we do for them and even like what they get when they're in the hospital and when they leave the hospital is just, it's vastly different. When we talk about health inequities, it is affected by like what healthcare systems exist and what people can navigate through.
Yeah, I feel like I'm in a place very similar to Had, but my residency program is also multi-hospital system. So we also have a county hospital, and most of those patients are on public health insurance, so like Medicaid. And then we have an academic center. And then we also have the VA hospital. And for those listening, like the VA is the special hospital system that we have for veterans, and the government pays for their care. Just like brief things that I've noticed, when I am at the county hospital on wards, what I can offer to patients is very different to what I can offer patients if they're like at the academic center. The resources that are available, it doesn't really have anything to do with the skill level of the physicians, because they're all like, a lot of our docs, they bounce back and forth between the county hospital and the academic center. But it's, for example, today we were talking about stress test echoes, and we were talking about the different things like what testing's even available. And we were saying, here at our hospital, the county hospital, this is what's available. And then like all these other fancy tests, like these exist, but we can't offer that to patients here. Like that's only available at the academic center. And so it really does drive, it can impact the decisions of like what tests we order and really the care that we provide. And as much as we try to do the best that we can, it's still like you're on the wards, and it's like what type of anticoagulation plan they're going to have is really dependent on the health insurance they have. And that's like unfortunate, when really the question should be like, what's going to be the most optimal treatment for this patient?
Yeah. I find it just so frustrating because we talk about like evidence based medicine and like we're like taught to think about what's optimal. And then at the end of the day, we can't really make those decisions because of what access to the system that the patient has. And I find it really does drive health inequities and it keeps like perpetuating it.
And it's unfortunate. Yeah, I feel like when patients are preparing to leave the hospital, it's like pharmacy always has to be like, let me do some prior auths to figure out like, can they even take these medications when they leave the hospital? And you're just like, I wish that wasn't the case, because then we end up being like, well, this is not the ideal thing, but this is what they can get with like the insurance that they have. Like as a provider, it kind of feels icky. And I think, again, this has always been the reinforcement of like, this is why I need to understand the system, because like at the end of the day, like I want patients to go home with the best thing that is available to them. So what do I need to understand to like be able to address that?
And I think it's just hard because I think for most medical like students or like most providers, unless you actively choose to like, for instance, get a master's in public health or to like learn about public policy or things like that, you aren't given the tools to really understand it. And then you end up as a resident and suddenly you're navigating it while working like 80 like plus hours weeks. And it's really hard. It's kind of frustrating. And I sometimes wish our system itself could be simplified. I've seen other health systems that aren't this way. Like I remember my personal experience. I once had to like go to the emergency department in France, and in the US with the like pretty solid insurance that I had at that time, it was maybe $200. My like actual bill was like thousands of dollars for this visit. And then in France, I wasn't insured and it only cost me $40 for this emergency like visit. And I was just sitting there and I was like, what is this? I don't understand. And what's wild is I feel like multiple people, whenever I tell the story, they're like, oh yeah, I've had this exact experience in this other country where similar thing happened.
Yeah, okay, so Tonga is like an inverse of the US. So I would say that the US is primarily a private system. So we pay through a lot of our healthcare through private sector, but Tonga is the opposite, where the government pays for it. There is the option for those who have money to pay privately, meaning they can pay directly to physicians at their clinic or whatever. It was funny because they're like, oh, if you get sick, it's okay, you can just go, and like you don't have to worry about the bill, because like they're like the government's gonna foot it, even though I'm not like a Tongan citizen officially. And so it's like interesting to think about how people like approach going to the doctor differently or to the hospital, because they know that someone else is going to be paying the bill. What ends up happening though is, because the government is paying for everything, there's not this unlimited budget. So the government has to say, for diabetes, for instance, like they don't have the money for like even stuff that we would consider to be kind of like a part of basic like diabetes care. Like everyone there just does like insulin, and we don't really have the choices to use other drugs. And that I think there's a lot of barriers that come with that. But I guess all this to say is, because the government pays it and they don't have this unlimited budget, it means they have to be very restricted in like what they can and can't give people. And so if patients want something that's outside of that, then they're going to have to pay for it out of pocket. And so I think that's the downside of, it's so great that the government pays for it. And I wish everywhere could be like that. But because of like the strained resources, they can only offer people so much. So then it still leads to this inequity, because the people who can afford to pay for the higher end stuff, like they will be able to pay for it, but the other people who won't. It was interesting when I went there, I like went around the pharmacies there, like a lot of them, you don't really need a prescription. As long as you can pay for it, you can get it. My aunt had cellulitis. And so I just like went up and I was like, these are the antibiotics I want. And like, they didn't ask me any questions. I just like paid the $4 for it. And they just like gave me the antibiotics. And I felt kind of sketchy about it, because I was like, I'm just a medical student. But I like had other patients too. They like came into the hospital and they've been taking like steroids. They've been taking prednisone for their gout for years, and they were having like all these side effects. And I think that's like the other downside, is because it was like not well regulated, then like people end up taking things that could actually be really harmful for them. But I did a lot of exploring at the pharmacies. Like there's a lot of different private pharmacies in Tonga just because I was curious. And one of the pharmacies is actually ran by basically a nonprofit organization from New Zealand. They would subsidize medications, like more expensive meds. Like the one that keeps coming to my mind is like a DOAC for anticoagulation.
For the listeners who don't know the acronyms, DOAC is like direct oral anticoagulant. And the direct is, I'm trying to remember how it is, like it acts on a factor, like it just acts in a specific part of the pathway to like do coagulation.
Thank you. Sorry. This is too much residency, and like I forget I'm like a real person and this is not sounding like it, but I think some common drugs that people may have heard of is something like Eliquis or Apixaban. And so a lot of patients, like they couldn't afford that in Tonga, so they would have to take warfarin, which is a much cheaper drug. But the thing about warfarin is that you have to have a lot more monitoring, so you need to go in for like essentially like weekly blood tests, and that can be a really big burden on people. So they end up having all these patients on warfarin, and then things get out of whack, and then they come in bleeding because they haven't been monitored. But sorry, I'm getting off track. The pharmacy, they were telling me for people who can't afford their medications, they can give it to them for a very subsidized rate or for free. But the problem is they're giving medications from New Zealand that people have returned. So in New Zealand, people can return prescriptions. They can be like partially open or whatever. And so what New Zealand does is they take all of these medications that people have returned and then they send them to places like Tonga. But then people being able to continue these drugs is all on the like contingency that they continue to get these drugs from New Zealand. And like you can't predict like what people are and are not going to return. So then the question is like, should they even be started on this if I can't guarantee them a supply or if like they can't guarantee to pay for it? I felt like internally conflicted about like that situation or just like the pharmacy situation in general, because I think it's great that we can offer universal healthcare, but in a place like Tonga where you have very limited resources, government has to make like tough calls. They can only offer so much. And then because of that, we still get these health inequities and then weird things like happening like this in the pharmacies. And so I think that's something that I learned from that trip was like there's a lot more than just like giving everyone universal healthcare. Like you have to be able to like see the problems before they even like arise, and some of that like I just don't know how you predict those things.
It's just like it is that thing where I feel like whenever I'm trying to like imagine an ideal state or trying to imagine how, because as we've established, healthcare is a human right, how we are able to ensure that people are able to reach that, I always feel like really stuck, because even in systems that we talk about that seem like so much better than the system that we know of, there's a lot of like complexity to it, and inequities like still run like quite like clearly. And I've just been thinking a lot about, I'm currently in a medical education pathway, and we talk a lot about like curriculum design. But when they talk about curriculum design, they always talk about like predicting and thinking about what's an ideal state. What are like people's needs? What are like barriers that we anticipate seeing? Like what are the other stakeholders like involved in it? And I feel like with curriculum, it feels a bit more tangible to do it. But when I try to apply that into thinking about the greater like healthcare scheme, I just feel so overwhelmed because I really don't know. Like as I keep looking at different health systems, like the National Health Service and like the UK health system. And then I hear like people who operate it in it and they go like, these are like the negatives of this system. And it's just so hard because there hasn't been a solution that really like targets the inequities and like really like gets across and like makes sure that everyone is able to achieve that basic human right.
You know, so a lot of like my year when I took my year away from medicine was like comparing different parts of different healthcare systems, and like that's really what I took away is like, okay, maybe this country does this better than the US, like maybe they can regulate prescription drug pricing, but then they have more like primary care doctors, but there's always like this other problem, like you said, like takes 2 years to see like a subspecialist, and there's no like incentivizing for people to continue their schooling because they're paid the same as the primary care doctors, and like often just experience kind of like the opposite edge of the pendulum of like the problem. And so I don't have anything like really insightful to say other than like other countries do some things much better than us, and there are some things that we do better because of our strengths. Like the US big strength is we are innovators, we have the greatest technology, we have the best of like everything when it comes to like techniques and blah 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 with when providing patient care. But with that comes we have the greatest health inequities. And I think that's something we as a country decided to like sacrifice, which is really unfortunate. And I think that that's the big thing I learned my year away is like when you get one thing, then you just open a different can of worms. And like you said, just trying to anticipate what those things are is really what will be helpful. And I've reflected a lot on the Tongan healthcare system and some of the things they could consider doing. But then every time I think if they do that, then what's the next problem that's going to come? And so one of their other issues is they're losing a lot of their doctors. They don't get paid very well. The government pays them. And then they end up leaving and going abroad because they're going to get paid more. Then you think about like, well, if you pay them more, then what, or like every time I think like, what if you did this, then I see I'm like, this could happen. And it is really a complex thing, but the way I think about it is like trying to address it from the perspective of health inequities, because to me, that's the most important thing. And that's, like I said, some people care about technology and some people care about whatever it is. But for me, it's always approaching with like, what's going to help people receive the best care that they can get and become the best that they can be. To be honest, kind of discouraging sometimes, but it helps me keep fighting to look for solutions.
And I feel like I just sometimes, maybe I'm just too, I like both like operate in that cynicism and that optimism. But I think that's the only way like you can move forward, like when you're in medicine in a way, is both being like looking for change into making things better, but then also having hope that things will get better. Keep hoping that eventually one day will like solve health inequities. There's so much more other things that are compounded that explain health inequities. And this is like, we like talk a lot about it a lot on this podcast, thinking about things like race, sexuality, gender, like socioeconomic status, which we've kind of alluded to here in this conversation, or even like where like you exist in the US or not. And I recognize there's just so much nuance to it. And that's why I feel the problem is really difficult to solve. But if I don't like have hope, I go like, then why am I here doing this thing, coming into medicine, trying to like create change,
Yeah, I feel like it can be kind of discouraging. I felt like the first 2 months of my program, I was like, wow, I'm learning so much. It's so cool. I'm going to be able to change so much. And then I was like, wait, the more I understand, actually, the more confused I am. And then the more overwhelmed that I feel. But then you see people who have done incredible work and you think, okay, maybe I can't change it on that large of a scale. But even if I tackle this, like, some people, they work their whole career to tackle prescription drug pricing. And when we saw the cap on insulin pricing like happen, like even though it was only for Medicare patients, but like that's a step in the right direction. And then you think about like how many people that helps, like how many people couldn't afford their insulin. And now like maybe they're one step closer to being able to afford their insulin. It inspires you that like, even if I address just like one little thing, or like anytime I address a problem, if I think about like, who are the people that are the most hurt by this problem? And if I make a policy that will focus on them, then we can figure out the rest of the things and try to anticipate it. I definitely have moments. It's like a roller coaster. Some days you feel good. You're like, yeah, I think I'm addressing things. And then the next day you're like, wow, I'm just a part of this like bigger system that's actually really harmful to a lot of people. And it can feel really icky, especially as like a resident. But I guess we just keep fighting.
Yeah. I feel like it's that pendulum of like when I start feeling good about something, like the world is like, hold up, you're like being too positive here.
Yeah, it's not even every day. It's literally every patient. Like you feel good one patient and then the next patient you just get destroyed. And that's just how the job goes and it sucks.
It's there to keep you humble. And I think it's important because I think it's those moments that help us re-reflect, right? And then like keep striving to be better and to create better worlds. One of the things I just want to close with is just thinking about, as we've talked about health systems, just kind of reflecting on a personal commitment or action that we really want to like consider based on this conversation. And I think for me, it's to continue to like assess and to continue like thinking about the health systems that I exist in, and like doing this due diligence of comparing and contrasting and thinking about it a bit more critically, because I think by being more critical, I can better like realize or recognize how to like ensure like more equitable care as I navigate different systems, especially for the systems that don't get as many resources as they could. And I'm curious, what would your commitment be, Siale?
I echo everything you said. And I think right now for me at this phase in my life is like, I feel like I entered residency with so much passion, and like I'm only like month 4 and I found myself already being like affected by the burnout. And then I have had like experiences that I like looked back later and I thought, I could have advocated better for this patient, or I could have been better in this scenario. And so I think for me is like not letting training like weigh me down, that I forget the big picture of why we entered medicine, and that sometimes it might take some extra time to an already like long day to make sure that people are being advocated for, and that can be really hard. But my commitment is to like continue to check in, and even if I can't always address it right in the moment, to like at least be able to find people who can help me address that when capacity is right. Anyways, to keep fighting.
Yeah, I think that's really beautiful. And I hope that for the listeners, the conversation today like has started for you to also think about things and to think about your own commitments too. And I always like just want to put this caveat that we're like talking about like really like complex things about like health systems and stuff that I'm still like learning. I'm constantly learning. And I will also say there's like probably like a lot of different podcasts that can like break down health systems, or like readings and like a lot of different things. And we're just all like learning together. And I appreciate Siale and our listeners for like learning with me today. I hope that you're able to reflect. Keep like listening to us wherever you podcast. Follow us on Instagram at Bundle of Hers, and don't forget to like rate and review. We like love having y'all.